Hey, good morning, everyone. Welcome to day 3 of Faculty Research Week. I'm Tracy, a lecturer at the Department of Human Nutrition and Dietetics, and I will be chairing today's session. So we're first going to be starting with a welcome message from Prof. Millereri.
Good morning once again, colleagues. Thanks for being here. We are really thrilled, very much excited to be here this final day of the research week. It's really been an amazing time. We've explored great ideas in the past 2 days. We've met with various talents, presentations that sparked off those curious minds. And honestly, today we are excited that we are wrapping up this phase of this journey. Remember, research is not a destination, is rather a continuous journey that we need to continuously embark on. And for us to really maximize all the benefits therein, we need to be creative. Creativity in connections. We need to be very, very creative in having those strategic connections. So today, please explore the opportunity during the campfire sessions. Just collaborate. Ensure that you're not living here the same way you came. Make sure you have someone you're going to work with, you're going to start with. I tell you something, last year, we had a session like that, and from there, we started working with the business faculty. So please, let's make those networks, those connections that will enable us to explore new horizons that will cause us to push boundaries. So we have really great, exciting presentations today, quite interdisciplinary. I'm sure you will really be excited to listen to these experts from various fields talk about what they have done and where we can actually make inputs. Yesterday was so exciting, especially the fact that we had the 3 directors of research from the institution, and they were actually here to show us things that we may have ignored or not have emphasized on. Today will be much more glorious. So please, I want you to just stay put and make sure that you're not distracted. We have important sessions like departmental showcasing, and what that actually means is departments showcasing their offerings, showing us what they do, because at times we don't know exactly what they do. Yesterday, or maybe it's the first day, a presentation from a department was very close to another presentation from another department, and they never knew. I was telling us that we might be saying there are not, many resources or maybe staff, but if we collaborate, it might palliate the tension that we experience by working alone. So please, let's make use of this opportunity. Once again, thanks for being here. Thanks for your tenacity. Thanks for your energy. Keep the momentum going, and I'm sure we will have great testimonies. Thank you so much, Ebuch. And before I leave, permit me to specially welcome the Acting Dean of the Faculty of Health Sciences, Professor Van Rooyen. Thank you so much for all the support. You're welcome.
Thank you, Prof. So there's actually a change in the program. We will be starting with Prof. Hussein's presentation, which is an online presentation, and the title has changed as well. The new title is Validating Mentorship in Nursing Education, an Egyptian Perspective. Thank you, Prof. Thank you, Prof. Hussein.
Good morning for all, and let me thank all the organizing committee, scientific committee, and Professor Millereri. Thank you for giving this opportunity to start with you. One of my work today is one of the studies published last year in one of the international textbook. The study is talking about validating mentorship in nursing education, which is an Egyptian perspective. As we know that mentorship is one of the educational strategies that are important in nursing education because it enhances the relationship between educators and the students, as well as to develop nursing students' self-esteem, self-confidence, and the professional capabilities. The aim of our study was to analyze mentors and mentees' perspective regarding mentorship as an educational strategy, and to identify the benefits and the challenges of implementing this strategy in nursing education. So the subsequent objectives from this study, the first one is to describe the concept of mentorship as one of the educational strategies, identify the benefits and challenges for implementing this program, analyze mentors and mentees' perspectives regarding the overall goals for establishing and validating a formal mentorship program, and finally, to propose suggestions and recommendations for maximizing the efficacy of mentorship as educational strategy. The design of such a study, it is a small scale descriptive study, and we selected for such study 4 mentors and 17 mentees at the Faculty of Nursing at Alexandria University, and we used a structured interview schedule, which was designed to be provided separately for each of the 2 groups, one questionnaire for the mentees and one for the mentors. And we did this interview through phone and WhatsApp to be easy to access to the sample. We used 4 ended questions for mentors. These questions were provided, and they were asked about their perspectives and experiences related to the competences or qualities they gained from mentors' experiences, the advantage or benefits they have gained, or challenges they have encountered in the mentorship program. Also, we asked them for recommendation to improve the performance with students when carrying out their duties. And finally, how would they rate their mentorship experiences? For mentees, we set 6 open-ended, 5 of them were open-ended questions, and 1 structure one for by using dichotomous response yes, no. The first one of the open-ended question asked the mentees about the competencies and the qualities they gained from the mentors' instructions. The second one is the pros or benefits of mentorship they experienced, they passed through. Also, we asked them for the challenges they faced before and during their experiences in mentorship. What are the most important lessons they have learned from their experiences, and how they recommend using their mentorship for other students. And this was the response was dichotomous, as I mentioned, by yes and no. And in case of both response, if yes or no, explain the reasons. The main results of such a study, 4 themes have emerged. The first one is the characteristics of effective menteeship, the most important benefits and the challenges. The third one was the general feedback about mentorship experiences, and finally, the recommendation for improvement of mentorship program. For the characteristics of effective mentorship, the most important characteristics was having for the mentors to have a strong scientific background, have effective communication skills with students, and having the ability to identify carefully the mentees' needs and provide them with continuous psychological support. Regarding the benefits, also the mentors mentioned that they provide an opportunity to foster the mentor's personal and professional benefits, help the mentors to identify his or her weaknesses and to improve himself or herself, and help to have the ability to deal with difficult mentees. And this is the last one is very important for us, because sometimes we face really on the ground some difficult mentees, and how you can deal with is very important for the mentors. From the perspective of mentees, the benefits that they gain is impartiality and objectivity in assessing the mentees' research interests, and the clarity and simplification of the information they gained through their experiences. The main challenges resulted from this study is the limitation of time, which is the main barriers to provide guidance from the mentors to the mentees. Also, the mentee's learning abilities and his or her attitude may hinder from achieving the goals in a specific time. And as I mentioned in the previous slides, some difficult mentees may hinder the communication between the mentors and the mentees. Mentors' heavy workload is another factor which is considered as challenges, and from the perspective of mentees, difficulty matching time between the supervisors or the mentors and the students is a very critical point, which is considered as a challenge for them. Also, the work climate sometimes is not supported for discussing the work between the students and the supervisors, which make it difficult to adhere to the time plan due to many external reasons. And this is the opinion or the perspective of mentees. Also, lack of support and the interpersonal conflict between the supervisors and the students are very critical to the continuation of mentorship programs. Regarding the general feedback, all mentors expressed that, however, they were struggling and interested in dealing effectively with their mentees, but still the experience was very stressful at the beginning. While by experience and gradually they became more confident and satisfied with all what they achieved. Some mentees mentioned that it was a very excellent experience and successful for future journey for them. Also, some mentors and mentees thought that it was a time-consuming, in general, as a general feedback, it was a time-consuming, which is maximized by the shortage of mentors, poor interpersonal relationship, lack of support, lack of time, and overwhelming overworkload for the mentors, and finally, uncooperative mentees. These difficulties, of course, have a detrimental effect on the nurse-mentor program efficacy. So, the final recommendation we gained from such a study is to increase the time of the debriefing session between the two parties, set weekly objectives together between the mentors and the mentees, the mentor's workload should be taken into consideration from the top management to increase the efficacy of the mentorship program, and there is an increased necessity for continuous formalized mentorship programs and academic leaders to consider barriers, facilitators, models, and components for success. This is my quick presentation. Hope it provides some insight regarding our study, which was a very small scale study. Thank you for attendance, and let me know if there are any question regarding the presentation.
Okay. Thank you so much, Prof. Hussain, for a very interesting presentation, a very useful research study. I'm a PhD candidate, so I have several mentors. So it's a very interesting topic to me. Are there any questions from the delegates? Okay. Thank you. I'll ask a question. So in your experience, do you think it's better if mentees can choose their own mentors? Does that facilitate the relationship better? Or is a process where you're just assigned a mentor, more like effective? Or like what is the difference between those two things?
It was very important for us to see how both parties perceive the work in collaboration with each other. And for us, it was very important to also to see from the mentees how they perceive the communication between themselves and the mentors. This is one of the studies that we used to improve our program in the mentorship program. So it is a very small scale, and it was very important to see on a progress how they can provide inputs for improving the relationship between them and the mentors, their mentors, and what are the main weaknesses and benefits they gain to build on. This was the main points for such study.
Thank you, Prof. Thank you, Prof. Hussain. Okay, there's another question from the floor.
Morning, Prof. Very interesting presentation. In terms of the recommendations, I think it's very practical. I just want to know, in terms of rolling out these recommendations and introducing it to nursing education, how do you foresee that will happen?
Yes. Thank you very your question. And we already submitted these recommendations for the leadership. And on the school, we are geared toward making a specific time for both mentors and mentees in collaboration with each other. Because sometimes the mentors take full responsibility for determining the time which can be the mentors is available, but without considering the mentees' responsibilities and the schedule. So this is one of the main points we recommend for the leaders, and we start to put this in collaboration between mentors and mentees. We set extra schedule even through online or face-to-face physically. Either there is an opportunity and time for meeting within the physical building, or on maybe through online meetings, something like this. So according to the opportunities for both mentors and mentees, there is different options set for both parts. This one of the recommendation. Regarding the workshop, the workload for mentors, yes, the leaders started to set a balance between the academics in terms of lectures, research, advancement, all activities regarding research at one side, and the time given to mentorship process is one of the main target to be a balance between the three components to have sufficient time to give more confidence, more collaboration with students, and more support for the students as well as the mentors. And let me say something, because we have a lot of workload in our school. So we are linked to different activities like research, teaching, mentorship. So we try to redistribution the workload to give the maximum benefits for both parties and to have sufficient time for each of the three main components. Is it clear?
Yes, yes. Thank you, Prof. Thank you so much for taking the time to present your research today. We really appreciate it. Thank you.
Thank you. Bye.
Bye. Okay, so the next presentation will be from Dr. Shale, and the presentation is entitled, What Does the Ocean Have to Do with It? Intersection between Health Sciences and Aquatic Research. Thank you, Doctor.
Good morning, everybody. I'm going to sort of work between them showing my slides and me looking at my slides. So, and I won't be presenting any data per se, but more delving into ideas of how we can work together in the ocean sciences space, whether you're in health sciences or the Faculty of Science or law or etc. So it's more, there we go. You can do presenter mode or presentation mode. Excellent. Oh, and a pointer, maybe. We'll see. See if I can do this. Okay. So first of all, I'm Dr. Denise Shale from the Institute of Coastal and Marine Research. I just started there as director. It does work. Okay, sorry. I'm working with the technology. And there we go. In March as full-time director. And so basically, just for those of you who don't know, what is CMR? We are an institutional entity. So that means we don't sit in a faculty. We don't sit in health sciences. We don't sit in science, even though our origin is probably is science. But we have members from every faculty. Hello. There we go. Let's make sure I get the right things here. Or was that you guys? somebody changed my slide. Okay. Okay, so, okay. Okay, I thought I was doing that. It wasn't me. Basically, as I said, we were, well, they get their things together. I can at least speak to it. Because like I said, I'm not actually sharing data, it's more ideas. So we have members from all faculties, health sciences, science, EBET, BES, humanities, law, and education. We have a range of this range of expertise enables us to promote the UN Ocean Decade priorities. Hello, we are still, go back a slide, please, because you, okay, can you do it, or, No, it's not moving. Because you're sharing your screen. I don't know if I'll. Okay, pretend it was a no, wrong way. There we go. Okay. So the UN Ocean Decade priorities, from pollution, which starts, this is not a very, okay, anyway. Pollution, ecosystems, sure I don't fall. Pollution, ecosystems, and biodiversity, sustainable fisheries and food security, economic sustainability and justice, climate change, resilience to climate change and to environmental disasters, looking at global ocean data and observation, making sure that we leap into the digital world and capture that and map the oceans and have wide access to digital resources, basically ensuring that our communities are in touch with the sea and the ocean and the coast and our water resources. And we are building up that capacity in which to do so. So we as CMR are actually in a really good position to look at these decadal priorities. Obviously, we have our strengths, but because we are university-wide, we're able to tap into expertise across this and work with people across this. And in terms of sustainable development goals, obviously we're anchored in climate action and life below water, but we connect to everything: reduction of poverty, social justice, good health and well-being. And that's actually what I want to show you guys today, where we can fit together. Either you centering yourselves in your discipline with sort of in that ocean frame, or working with other researchers within the ocean sciences. So we also have house 5 of the research chairs within CMR, in its shallow water ecosystems, which is Professor Janine Adams, Law of the Sea, which is Professor Patrick Franken, Ocean Cultures and Heritage, which is Professor Rose Boswell. Mandy Lombard is the Marine and Spatial Planning Chair, and the Oceanography and Food Security is Professor Mike Roberts. So we have a lot of really good expertise in terms of our chairs and our academics. We have about over 300 members of academics, RAs, adjunct professors, honorary professors, students, and we have very close collaborations. And if you're in this building, you'll know SAON, which is a South African Earth Observatory, who collect data on the coasts and are funded by NRF, SAIMI, Fish Force, etc. So we have quite a wide footprint. We have great collaboration with Professor Mallory on her work in aquatic sciences. And so I'd encourage you guys to look into how we can work together and how would we do that. So I'll do mine, and you've seen this slide 100 times now. This is adapted from the field guide from Utrecht about transdisciplinary work, because transdisciplinarity is the big thing at the moment, okay? But not everyone actually understands what that really means. So I'm just going to walk us through, starting with discipline-specific research. So as you can see from the key here, the white circles are shared knowledge, the black circles are our discipline, the yellow bars are academic knowledge, and so we go from our discipline of academic knowledge to answering the questions that we want to answer. So how do we do this? So if I am a dietitian, how do I integrate? How do I frame myself in the sea? Wrong slides. Okay, so there are more. I've just put out some ideas here where we can have connections. So in dietetics, you can be doing research in the nutritional value of seaweeds and different types of seaweeds and how they're used. You can also branch in, if we want to branch into the multidisciplinary, what are the cultural significance, et cetera. So, but for this, we'll just stick with that. Also spirulina, which is a health supplement, which sort of bridges sort of pharmacy, dietetics, et cetera. So those are things from the sea, from the coast. If you're in environmental health, occupational health and safety. So how do we research occupational health and safety on a ship, on a fishing boat, in the harbors? So there's that ocean science link there. I said EMS instead of EMC, but you know what I mean. Emergency healthcare services, sea rescue. So how do we research how best to do that? So there's also occupational safety. So there are those links. Pharmacy. So there are lots of things, both terrestrial and aquatic. How do we look at some of the products in the sea that can be turned into pharmaceuticals used as medical therapeutics? So that would be framing your research in your discipline, but using the sea or ocean or coast frame. Okay. And also mental health. What is our human connection with the sea? How does that ground us? What's the psychology of it? So that's another example. Okay, so we go dueling. Okay, so we can expand in that. And so we have our disciplinary, which we've explained. Now we have multidisciplinary work. How does that work? So you see what we have is that thematic umbrella. So we have a question, a central question, and everyone's working on it within their discipline to that one common umbrella. So, we're investigating findings. So we have our aquatic research can inform health, and health sciences can also inform our aquatic or conservation or ecology work. So for example, studies on waterborne pathogens, so bilharzia or schizostomatics. And there's an ecology and there's a whole ecosystem part of that, but then there's also the human transmission. How do we stop it? How do we branch? So that's working on one thing, but from different perspectives. So let's see, we can go from there. So I've just used, dueling things. I've just used this as a basic catch-all to just show the different areas of multidisciplinary study. So we've got an array, in this case, ocean creatures that can be used in different ways in health sciences and could be worked together, because it takes, medicine, pharmacy, nutrition, safety, environmental health, and a few others that I don't have up here. But you need to interact with the biochemists, the taxonomists, the conservationists. We need to look at the economics of maybe using these things for pharmaceutical, for example. But we also need to look at the ecology of exploitation. So that's an example of taking that sea lens, but then bringing in other disciplines that you would work with. In nutrition, foods and healthcare products, you might want a biochemist or a toxicologist or somebody else to inform you about the use of those products, so that way your research can be informed as to the use for humans. So that's basically the schematic there. The sea cucumber, like I showed you with the pharmaceutical, we actually have somebody here who dives, who collects, who works with somebody at Rhodes, who's a biochemist that looks at extracting the products for future use of cancer treatment. So there are a lot of things we don't know about some of the plants and animals in our environment and in the sea and in the estuaries that actually could be utilized for health and in different ways. So yeah, do that and that. Okay, so then we go from that multidisciplinary to looking at interdisciplinary, crossing those discipline boundaries for a shared knowledge. So there's a difference between interdisciplinary work and transdisciplinary work. So interdisciplinary work is still driven on an academic level. You see that orange or yellow square. Whereas the transdisciplinary work isn't solely driven by academic knowledge. It's also driven by our communities. So the best case scenario for sort of transdisciplinary work is a community says, we are small scale fishers. We have these problems and we're interested. We also have this knowledge and we have these data. We have small scale fishers that can tell us just as much about the effects of climate change on their livelihoods as we can with our data and our models. So we need to listen to them. But they have other issues that might be driving across disciplines, such as we have a lot of drownings. So how do we prevent that? So do we get involved in research with human movement science on swimming and developing that? Do we get involved with EMC? I'm going to get it right. EMC, to know how we can best protect ourselves when we're carrying this out. Our communities, our families are affected. So if you have a female or male-led family who are these small-scale fishers, how do we make sure we maintain our family cohesiveness in the social work realm? So I guess what I'm trying to do is just give ideas of how we can work together across different areas. Bridging the conventional knowledge within the theme with solving a problem, and that the government is interested in too. So how do they better govern the small scale fishers without excluding them, which is another problem in social justice. So we have governance, we have laws, we have the means to enforce them, but are we excluding people? How do we maintain that inclusion? So those are some of the things that we can work across the different disciplines to develop. Okay, I've just got a few examples that I pulled. So microplastics is a big thing, okay? Plastics in the environment that become microplastics, they get incorporated into our food, essentially, and then into us. So this is an approach. So one environment, one health. How do we conserve and protect our environment and use those things to make sure we protect ourselves? Because we are humans and we have a self-centered look at things. So how do we look at that exposure? How do we protect the wildlife? How do we protect ourselves? So this is just one, sort of simplistic example of how we can do multi and transdisciplinary work and interdisciplinary work. Harmful algal blooms, okay? So both in fresh and coastal waters, climate change has a big thing to do with it. Our input into the environment has a big thing to it, but this means different things to different people. If you're an asthmatic, the spores that happen when these algal cells are dying and go into the air, become aerosolized, will trigger people's asthma. People who don't have asthma can be triggered by this because some of these things are cytotoxins. That's why you have dead fish. It's not just oxygen depletion, but it's also the effect of the decaying algal cells and the toxins that the algal cells have. So it's a health risk. It's an environmental risk. So how do we tackle this large global problem that's caused by climate change? I mean, the same with waterborne diseases, with schistosomiasis. So right now we know the areas that it exists. We know where the snail is. We're getting to know why it wants to be where it wants to be and how the transmission of the fluke is. But now climate change is changing the ranges and where these snails are, which are the intermediate host for the pathogen. So we need to understand the effect on the ecology and why it might be moving up the coast, down the coast, inland, outland, how does it affected by drought? How is it affected by the flooding or the extreme events? And how do we protect ourselves and our children from the disease? So these are examples. Like I said, I don't have any data. I just have examples of where we could work together. So this is just a general schematic of it. So you have eutrophication, which means we've put a lot of nutrients into the land and the waters because of our, living on estuarine, riverbank, etc., dumping things in fertilizers or ourselves. We also have global warming, so you get harmful algal blooms. Then you have food poisoning, subacute or chronic effects, and then co-exposure. So those are things that medicine, nursing, I mean, all of this transcends just working on the ocean and on the algae themselves. Also, what ecosystem services are going to be hindered. So small scale fishers that need that fishery, the fishes are dying because of how does that affect them and their society, their social well-being, their community well-being. Then you have closures of shellfish farms. What are the economic losses? So health sort of centers around all of these things. So if we have this environment that is not conducive to us in terms of our direct health, but our community health and our economic health, that has big implications. Okay. So basically, I think I'm done with my talk. So I just want to show you, it's also nice to work at sea and on the coasts and in the oceans. In wetlands, I come from a freshwater background, so I don't want to exclude that, but estuaries and Marion Island and dolphins and all the sexy animals too. So I just want to encourage you, if you have some ideas where you want to put your work into an ocean sciences frame, or if you want to be collaborating, please feel free to come see me and see who I could maybe hook you up with, who's doing what. That's sort of my role in encouraging more research. And, we do have extensive international and national connections as well. So we're always interested in broadening our family. So, okay, thank you very much.
Thank you, Dr. Shale. It's such an important topic. Interdisciplinary, transdisciplinary, no problem exists in isolation. So the way we do research, should definitely be more collaborative. Does anybody have any questions, Dr. Shale?
I don't actually have a comment, just thank you, Denise. And I'm just amazed at all the touch points in health sciences, and Rian from radiography also here was just making some very, very interesting comments about their role. So Denise, my question actually, is there a forum where we can do some brainstorming specifically with you from people interested in the faculty? Because I know also specifically some of the departments that's based on this campus, like emergency medical care, radiography, nursing, etc. They have been, talking about this, but is there a forum that they can access sort of to have a thinking session, or do they individually approach you as you indicated? Thanks.
Well, if there's interest, we can definitely have a meeting of interested parties. There is the Ocean Science Campus Test Team and workshops, but that's actually on a different level. It's not, that's more, it's broader. But I'm also been involving our students a little bit more to try and build a little more student community and have a little bit more support for them. I think it's sort of my background because I sort of I have a fun, so most of you probably don't know me, but I was in botany, but I'm a zoologist. I work on wetlands and estuaries. And then I was, so I've had students, I've had research projects. Then I was in research development, and then I was in research support and management. So I've sort of, in this new role as director of CMR, tried to bring all of those skills into the post in order to help both our postgraduate students and our academics in terms of grants and other support. So, but I would be very interested. I did, like I said, I didn't cover all of the different ideas I have, but we have the hyperbaric chamber. So that's also, yes, you use that for, if divers get the bends, they need it, but you've also used it for therapeutic reasons. So those are sort of the cross things. And also, I don't know if anyone had a chance to go to Bird Street last week to the South African Cultural Observatory event, which was with the Black Mermaid. So she's a free diver, one of the few people of color that does this. And that also that has implications for HMS in terms of the training. It has implications, and it's broad, and the connections are there. So it's that art, science, health science, and community all coming into one. So there's lots of scope, and if people are interested, I would be willing to host a forum, and we can get something together. I also want to say Research Week for the university is the 9th of September through the 13th. And CMR is having a session on the 10th from 11 till 4:30. And our focus is on inclusion and sustainability of natural resources or coastal resources. So basically fish nursery to law and governance. So there are things that I think would be interesting to those of you in health sciences. So I'll just make that pitch. So any other comments, questions? Thank you very much for your time.
Thank you. Thank you so much, Dr. Shell, for a very interesting presentation. Okay, so the next presenter is Dr. Oakes, and the presentation is entitled Exploring University Level Admission Decision Making Based on Access Testing and Undergraduate Admission Variables. Thank you, Doctor.
Get up and stand this side. So good morning, everyone. I'm speaking today on exploring university level admissions decision making based on access testing and undergraduate admissions variables. Okay, the clickers, no. You're not the only one. There we go. Okay, so it's about, it's about decision making, and we do this every day. But the problem with decision making is we don't really know how we go about making decisions. We just make them. And the problem with studying decision making is that there are challenges specifically related to the act of decision making itself. So some of the issues are that humans are decision makers. So there are limitations to being humans. We get tired, we are inconsistent, we use different types of information. It's a cognitive process, so it's covert. You can't see, and most of it is unconscious. We're not aware of the processes we're engaging in when we make a decision. When we talk about decision making, there could be a lot of cognitive processes going on. Are we making an evaluation? Are we judging? Are we choosing between choices? Are we weighing up information? Are we making a decision based on consequences? So there's a variety of cognitive processes involved. And then also decision making takes place in a context. So every single context has an impact on the decision making that could take place. And decision making is so important that there's a field of judgment and decision making within disciplines that has developed. So lots of fields are studying decision making: economics, statistics, psychology, nursing, management, education. And this whole field has emerged. And we can use a category of judgment research, specifically looking at a judgment, which is an evaluation of information to come to a conclusion, to describe what decision makers actually do when they're making decisions, by trying to understand how decisions are made. So to do this, we use two theories. The first one is social judgment theory, and it consists of a variety of concepts and methodological steps that explore in a real-life context a decision-making situation using something called the lens model. It explores the way people formulate their judgment policies, which is in essence the way they think about the environment. And we can use the lens model to structurally model the judgment process through multiple correlations, which capture the thinking on each side of the lens, and then compare these subsystems to determine an overall judgment achievement. So this is an individual thing, and you can look at you can identify a judgment policy of somebody and then compare how well they are making decisions based on how they are thinking. So here's the model. So you have on the one side the environment, then you have the lens of information, which are known as cues, through which the person makes the decision. And on the other side, you have the judgment. So on the left, you have the environment, and on the right, you have what's happening in the mind of the judge. And the lens model equation, which is the ultimate result of this, has a couple of predictors that you can use to understand how they are using cues, what cues they are using, and ultimately their accuracy of decision making. So if you look at that, on the left-hand side, you have criterion predictability. That is the best achievement level for a particular decision. The opposite to that, on the right-hand side, is cognitive control, and that measures the reliability and consistency of whether decision makers can apply their knowledge. At the bottom there, you have knowledge or matching. That is how well the decision maker understands the task they are making a decision about. At the bottom, you have correlation of residuals, or the configural coefficient, and that's essentially the information in the model that wasn't able to be predicted through linear modeling. And ultimately at the end, you get the top, which is achievement, which measures the ability of the decision maker to make correct inferences based on the cue information available. The other theory we use to look at decision making is something called the cognitive continuum theory. This is also a descriptive theory. It simultaneously focuses on tasks and cognitive processes, aiming to help people enhance or improve their decision making. It works on axes and continuum, two of them, a cognitive one, which has analytical on one side and intuition on the other, and a task one, which has ill-structured tasks on one side and well-structured tasks on the other. And they get put together to determine a cognitive mode. So the ones at the top, 1, 2, 3, are the cognitive modes that are analytical, and the ones at the bottom are the cognitive modes that are more towards intuition. And in the middle, you have something called quasi-rational thinking, which is a mix between the two poles on the continuum. So the research aim was to describe admissions decision-making by the Center for Access and Assessment Research Assessment Consultants. These were people who were making admissions decisions for applicants who did not meet the direct entry requirement to come to university. We wanted to understand how they were making decisions. And so the first aim was to describe their decision-making in terms of time, their perceived difficulty, the outcome. So they had to answer yes or no. Would we accept a student or wouldn't we? The Q use and importance across various programs and profiles. Aim 2 looks at the lens model equation and the accuracy of decision making. And aim 3 describes the cognitive mode of each consultant. So the research methodology had 9 steps to it, and I've put them out there because it's a specific to methodology to social judgment theory. So you conceptualize the problem, you understand what faces the decision makers, you identify relevant cues, and in this case we had 5 that were identified through semi-structured interviews. We sampled cue profiles, so we took actual decisions that previous decision makers had made. So the decision facing the decision maker was accurate in terms of how it really would have happened. We obtained a sample of judges. There were 4 participants. We looked at how they made decisions. We captured their judgment policies. We determined their accuracy, and then we identified their cognitive modes. We used an experimental research design that was a 2x2 within subject formulation with 2 independent variables, one looking at program type. So were decision makers making different decisions if they were faced with a student coming in for a degree program versus a diploma program? And then also, because we want to improve decision making, if we change the format of the information that's presented to be in line more with a cognitive mode, would we then get different decisions? So we had a phase 1, which was what decision makers were used to seeing, and we had phase 2, an adapted cue profile based on how they were thinking and their thinking policies. So if we look at results and discussion, right, for aim 1, there was considerable variability between decision makers and the phases and the programs. You'll see the results just now. They're incredibly variable. If we look at time specifically, the results suggested experienced decision makers following intuitive thinking policies. There were definite slight differences between thinking about diplomas and degree decisions, with diplomas taking longer and rated as more difficult than degree decisions. The decision outcomes were definitely affected by the change in format. A third of decisions changed from either yes to no or no to yes, based on the same information just presented in a different format. And diplomas seem to be more affected than degrees in the results. The regression analysis revealed that when the 5 cues that we looked at, the test results were used and seen as more important than the school results. So here you get an idea of decision making. So each one of those shapes is a decision maker. They're called buffalo, elephant, lion, and rhino. So you can see that There's a couple of common patterns. So degree decisions look different to diploma decisions. You can see that Buffalo, who is in red, is thinking very differently to their colleagues. All right. You can also see some cues that are really important. So arithmetic, which is AR, turned out to be the most important cue, particularly for degrees and diplomas in phase 1. You can see that when the profile changed, quite a lot of decision-making changed, particularly for the diploma students. You can also see that Buffalo didn't rely as much on arithmetic, but then was a lot on elementary algebra and reading comprehension, which were the other test results, and the school results, which is APS and maths, were hardly featured in the decision making at all. So if we look at aim 2, which looks at the accuracy of the decision making, again you see differences between degrees and diplomas. Again, you see Buffalo making quite different decisions and thinking differently to other consultants. More noticeable is in the profile 2, if you look at Lion, who was in green, Lion's decision-making is much improved and very, very accurate. So the profile change, the format change really benefited Lion's decision-making. And this tells us that we can train or change decision-making based on how people are viewing information. You can see that with the diplomas, there's definitely a lot more unmodeled information having an impact than on the degree decisions. In terms of the cognitive mode, all of them were thinking in a quasi-rational manner using mode 4 or mode 5. They used computer modeling, which is mode 4, when they were familiar with the knowledge templates. When familiar knowledge templates were not available or had changed, or when the knowledge of the decision was low. Right? So then when they were feeling unsure or things had changed, they moved away from being more intuitive up the scale towards being a little bit more analytical. When they had knowledge templates, for example, in the degree decisions and a high level of knowledge, then they sometimes used more cues as well. So that was really interesting for us, that even though we had people thinking very differently, they were all still thinking intuitively in more or less the same modes. So the contributions of the study is that it adds to scientific knowledge in the field of JDM. It's given us baseline research about decision makers in the admissions context, which has never been previously researched. Similar research can be done in other decision-making contexts and other universities by using a similar methodology and approach. And you can also use these findings to help with training in decision-making. And it doesn't have to only be in this context. It could be in decision-making contexts wherever decisions are made, if you have a reliable way to measure what is happening with decision makers. Thank you very much.
Thank you, Doctor. Again, a very important study. Are there any questions from the floor?
Yes.
We can check with online delegates. Okay, President's going to check.
I've had a question. Thanks, Elizabeth. It's quite complicated. So if you covered what I'm going to ask now, my apology. But how will this be rolled out to, assist students when they apply? Or what was the thinking about implementation of your work?
So this is a complicated one to answer. The problem is that the Center for Access Assessment and Research no longer exists. So the research was started and done in 2016, and the center closed in 2019. So we can't use it at the moment for our admissions decision making, but it could be used further in other decision making contexts. At the moment, our students are coming in directly based on their matric results, so we're no longer doing access testing for them, so we're no longer making decisions. If it comes back in the future and we decide to change our admissions criteria, we might be able to use this to train further decision makers and understand more about the decision making that's taking place.
Thank you, Doctor. Any other questions from the floor? Yeah, thank you. Okay, our next speaker will be Mrs. Wilson, and the presentation is entitled Strategies to Facilitate the Implementation of the Patient's Rights Charter in the Bono region of Ghana. Thank you.
Good morning, ladies and gentlemen. I'm so grateful for this opportunity to present on my work. My work, what I'm going to present today, is a part of my PhD work. The PhD work is looking at 3 different groups. We are working on patients, we are working on nurse managers, and we're also working on professional nurses to be able to develop strategies that will help with the implementation of the PRC. That's the Patient's Right Charter. So health, according to WHO, is a fundamental human right. And as such, every individual is entitled to the highest standard of quality healthcare and accessibility without being discriminated based on your socioeconomic background, your geographical location, or even your gender or color. And it was realized that most times patients were not accorded their rights even when they're accessing healthcare. And so most countries developed charters that seeks to promote and protect the rights of the patient whilst accessing healthcare. So for instance, when you come to South Africa, we have the Patient's Right Charter, all right. We also have the Batupele principles that helps with the implementation of the Patient's Right Charter. The implementation of the Patient's Right Charter has been linked to improved quality of healthcare and accessibility. It has also been linked to improved cost or reduction in cost. It has been seen to reduce the length of stay of patients at the hospital because patients are involved in decision-making and planning of their health. And so they always are able to abide by their treatment regimen, and that reduces the length of stay in the hospital. It also reduces the cost burden on hospitals and patients as such. Ghana has also enacted the Patient's Right Charter. In 2002, it was done by the Ghana Health Service and the Commission for Human Rights and Administrative Justice. After the launching of the PRC, there were workshops that were organized for major stakeholders in the healthcare industry. Health professionals were also given in-service training to be acquainted with the Patient's Rights Charter. But even though the Ghana Health Service is trying so much to help with the implementation of the charter, most times when you go to the hospitals, you may find the posters of the Patient Right Charter displayed in notice boards and on wards. But most times people do not know about their right. There have been studies that indicate that patients have low awareness level on the PRC. Even healthcare professionals do not know about the PRC. During our study, we realized that some of the nurses told us that they only look at the PRC when they are going for interviews, promotional interviews, or they are going for peer review. And so most times they don't know the component of the PRC. And that means that the implementation of the charter has not been successful. And that is why this study is aiming at developing strategies that can help with the implementation of the charter. based on empirical research findings through the exploration and description of experiences of patients. We are looking at patients this morning and the factors that influence the implementation. The study consists of 6 objectives, and the third objective that I'm presenting on is to explore and describe patients' experiences regarding the implementation of the PRC. The study is a qualitative study. We used explorative descriptive design because we wanted to know the experiences of patients and also describe those experiences that patients shared with us. Convenience sampling was used to select 12 participants. In our healthcare system back in Ghana, we have the public health system, we have the private, and we also have the quasi. That includes the faith-based and the forces and some other facilities. And so 3 facilities were selected purposively for this study, one being a public hospital, one also a private, and we also used the mission hospital for the study. Semi-structured interview was used to elicit the views of the patient, and the interviews were transcribed verbatim. The test 8-step approach to coding was also used for our data analysis. For the research setting, in Ghana, we have the region system, just like SA have provincial. We also have regions, and we have about 16 regions in Ghana. And one of the regions is the Bono region, where the study was conducted. At the Bono region too, we have about 16 districts. And the region is made up of municipalities and districts. And 2 districts or municipalities were purposely chosen for this study. You can also see that I have pictures of Queen Mothers and our kings here. So with the research findings, we had 6 teams from the patients' interviews. During the analysis, the first team that we realized was that patients described different roles that they have to play when it comes to implementing the PRC. The PRC implementation can be said to be all hands on deck approach, where everyone needs to play a part for it to be successfully implemented. So with the sub-teams, patients exhibited their knowledge on the PRC. Most of the patients, even though not all of them, indicated that they are aware of the charter, and some indicated that they are aware that when they are assessing healthcare, they can ask for the names of the healthcare provider. They can, or they have the right to know about their condition, and they also have the right to assess quality healthcare. Some indicated that they are able to demand for their rights. But even though some of them were able to demand for their rights, most of the participants that we worked with said they were not able to demand for their rights. And they gave reasons for not being able to. Some of them said that they fear the consequences. In our healthcare system, healthcare providers are seen as fathers. They assume this paternal role. They make decisions for patients. And so patients see them as authority figures, and they don't want to do anything that will make the quality of healthcare they want to assess. And so they fear the consequences that might arise if they should demand for their rights. For instance, this participant said that I am young, and I'm afraid if I keep on demanding, they will feel that I'm disturbing them. So I won't even ask. Another participant indicated that he feels that he'll be tagged as being problematic because he uses one facility. And the next time he goes there, he may not get the best of care he needs. And so they will not even demand for their rights. Another sub-theme that we realized was patient prioritizing their health over their rights. Most of them felt that when you are sick, you just want to be cured. You just want to be treated. And that is not the time that you go asking for your rights. So they prefer to get health care and go back to their homes without asking for their rights. So even whatever they do to them, even if they are hurting them, they are just quiet and they just want to go back home. The patients also felt that sometimes their own attitude hinder the implementation of the charter. They feel that sometimes when patients come to the hospital, they don't comply with the rules in the hospital, and that can prevent the implementation of the charter. The second theme also looks at the patient describing the roles that they perceived nurses are also supposed to play when it comes to implementing the PRC. Some of them felt that there was a lack of professionalism, that the nurses were not being up to their task. For instance, one person said that some of the nurses will be like, if you want your right to be adhered to, you should have come with your own nurses from the house, which they thought was unprofessional. One participant also shared his experience where his wife, who was operated on, was asked to clean the blood coming out of her because they felt that she has to do it, and that was unprofessional. The patients also described negative attitudes of healthcare providers mirroring the adherence of the PRC, and they felt that some of the nurses do not even know about the PRC, because if they knew, they would not be offended when patients demand for their rights. The third team also looks at patients describing factors that they perceived were influencing the ability of the healthcare providers in implementing the PRC. They felt that there was a lack of resources. They felt that there were challenges that the healthcare providers were facing. There was a lack of supervision and monitoring. And so they called on the managers and authorities of the hospital to monitor the people so that they will know whether they are adhering to the rights of the patient or not. Some also felt that if disciplinary measures are meted out to nurses who do not adhere to the rights of the patient, it will keep them on their toes and they will do the right thing. The theme for patients highlighting cultural factors. I brought a picture of our chiefs and our queen mothers. So cultural factors play a major role when it comes to assessing healthcare. And we observed that there was this culture of acceptance among the patients, that when they come to the hospital, they can't complain. They don't want to even complain when their rights are abused. They don't want to talk about anything. They just accept any care that is given to them. Some do that just to protect their integrity. For instance, this woman felt she was a grown-up. And so there are nurses who are young. And most times the patient feel that when they demand for their right, the nurses are going to insult. So for her not to be insulted, she prefers to just keep quiet and take whatever services she is given and go home. Patients also felt that the traditional authorities have roles to play so that the charter could be implemented. They felt that the traditional leaders could be advocates. They are highly respected in the communities. And so if they should talk about PRC, the health providers will follow and do the right thing. If they should have education sessions during community debates or community meetings, if they should talk about the PRC, people will be educated on that. Family also have a role to play. We cannot leave family out when it comes to healthcare delivery. They play a major role. And so the patient felt that they could also be enrolled in the implementation of the charter. The fifth team also saw patients talking about the roles of government. They felt government has relented on its roles and government was not providing the needed resources that was needed for the provision of quality of healthcare. So they felt government should enforce laws. There are laws there protecting the patient, but are they being enforced? So the patient felt that government should enforce these laws so that when nurses or healthcare professionals know that there are sanctions, if I don't abide by the rules or the patient's right, I may be sent to jail. If they get to know that there are things like that, nurses and healthcare professionals will make sure that they are implementing the PRC. They also spoke about government including the PRC in the curriculum of nursing training institutions so that before the student even comes out of school, they know something about the PRC. The last team, which is the sixth team, saw patients describing different roles of civil societies in the implementation of the PRC. They felt that the media could be a major source of education. There are so many radio stations in the region, there are TV stations, so these media stations could have programs that seeks to educate the general public so that the public will become aware of their rights, and that will help them to demand for their rights. And so media could be advocates and could also be a means of educating the public. They also describe the roles of NGOs and NPOs. One of the participants stated that if NGOs could train teachers, teachers in turn can also train school children. And right from the basic, they know that we have rights, and that will empower them to demand for their rights. So to conclude, these are the strategies for implementing the PRC that the government and healthcare facilities need to empower public and patients to understand the PRC and what it stands for. So healthcare facilities can educate people on the outpatient basis, or when they are being admitted into the hospitals, they could teach them about their rights, and government could also do public education so that people will know about their rights. There is a need for nursing education institutions to include PRC in their curricula so that nurses will know or have knowledge about the PRC even before they complete their training. Then families and traditional authorities also need to promote the implementation of the PRC. And we believe that with this, we'll be able to effectively implement the PRC. So to end, I will say, Danki, Giabonga, and Kosi Medase. Medase is thank you in Twi. Thank you.
Thank you so much, Mrs. Wilson. You know, we currently in our school, we're talking about pedagogy of care, you know, and it so strongly speaks to this topic. So thank you for that. Yes, I see a question.
Hi, thank you very much. It was very interesting. It sounds to me that you guys need to start with the nurses and the doctors, because from the excerpts of your interviews, it seemed that even though the patients knew that they had rights, they were very afraid and actually demoralized by trying to exercise them. So it feels like, unfortunately, it's like educating the practicing nurses, not only the ones that are coming up, might go a long way so that they'll feel more comfortable. But I love the idea of getting the traditional leaders, the kings and the queen mothers involved in making sure. But so is there, so to ask the question, is there a move to build that capacity and training in existing nursing at the hospitals of the patient rights, to see it as them being a partner as opposed to the being attacked? Because I have a feeling they feel attacked as well.
Thank you. So with the interviews that we had with the nurse managers and the professional nurses, some of them indicated that they organize in-service training to talk about the PRC with the nursing staff. But it was realized that most times the conferences or the workshops or the in-service were not really concentrating on the PRC. They just chip it in. And so most times the people do not get much. And so we are advocating, hopefully after this study, we can have interventional programs so that we can also teach or train nurses on the PRC. Thank you.
Thank you so much for a very insightful presentation, I must say. And this doesn't have to do with the project, but actually opening up new things that could be done if it's not factored in the other objectives which you did not present here. I think there will be need to establish, if there's a regulatory framework, you know, guidelines, even for the medical doctors or the healthcare workers, and maybe to try to have, it's very much in line with what Dr. Shea was saying, to kind of carry out a baseline evaluation of the knowledge of the healthcare workers, even with regards to the subject of interest, and then design appropriate intervention and evaluate post-intervention measures, and also to try and understand some of the facilitators or enablers of this particular subject, because there might be institutional, systemic, and cultural, organizational factors, as well as patient-related factors. So it's really a good study, I must say, and worthy of adoption in many areas.
Thank you, Prof. So with the objectives, one of them looks at developing the strategies. And so we hope that those strategies, yesterday I was listening to the Innovation Center patenting things, and I felt, oh, okay, when we're able to also develop strategies, maybe we could also send them to the Innovation Office so that they can help us to make it into a policy. And that could be used for the interventional studies too, and the programs too.
I just wanted to ask Mrs. Wilson, in terms of recruitment of the participants, what were some of the challenges? And then my last question was, wrote it down but I can't find it. But anyway, and then I'll ask.
Okay, thank you. So with recruitment, it wasn't easy. Sometimes I'll drive long distance to the place and they will tell you the next manager is not there. So you have to go and come back because we needed the approval. First, I had to, even though I had approval from here, ethical clearance from here, I had to also apply for another ethical clearance back in Ghana. And that one took like a whole year. So it wasn't easy. Then you get to the hospital and they tell you, oh, you have to come back later. So it wasn't easy. There were so many challenges, but we were able to scale all those challenges. Some of them, the participants, mostly the patients, we did not conduct the interviews in the hospital because we felt that it will not help them to come out to express themselves. So patients, where the interviews were conducted in their homes, and I had to also go into the homes of the patient. It was challenging, but we got through it.
So sorry, got my second question. Do you think that the results or the findings would have been different because this was conducted in a public or government hospital?
We used 3 different hospitals, a mission, a government, and a private hospital.
No,
yeah, to cover up.
Thank you.
Yeah. Thank you.
Sorry, any other questions? Thank you so much, Mrs. Wilson, and well done on an excellent study. So now we're going to do the fun part of taking a photo. So please, maybe kindly ask that delegates come up, stand over here for a quick photo, and then we will do the last presentation after that. Thank you. Okay. Now that our photo op is completed, thank you so much for that. The last session is from Mr. Bunmi, and it's a pre-recorded session. And the title is The Relationship Between Physical Activity and Body Composition Among Quintile 5 Primary School Children in Gqeberha, Eastern Cape, South Africa.
Demola Bumin. My supervisors are Doctors Super Sile Wanizo and Dr. Marina Bod from the Department of Human Movement Science, Faculty of Earth Science. The topic, I am so much interested and I'm in love with this topic because of the importance of it. The topic is the relationship between physical activity and body composition among Quintile 5 primary school children in Gqeberha, Eastern Cape of South Africa. Childhood physical inactivities has shown exponential growth in the technologically advanced landscape worldwide, as it was reported by Hal Amri et al. 2023. According to WHO 2010, physical inactivities in children contributes to sedentariness and associated obesogenic behavior, which increases the risk of becoming overweight and obese, even at young age. And despite all well-documented benefits of physical activities, it was reported by Herbert et al. 2022 that global situation of children and adolescents regarding physical activities is still not up to what is expected, because it revealed that only 27 to 33% of children and adolescents meet the recommended amount of moderate to vigorous intensity physical activities. And the question is, what about the rest? And we can see if this percentage met only the MVPA required for health and well-being, meaning that the rest who do not meet up will be suffering from certain chronic disease or the other. So we have just seen that globally there is now a decline level of physical activities. And also, not only in the world, it is also in our home. Decline level of physical activities and subsequent increase in sedentariness seen to be becoming normative lifestyle for many South African children. And there are evidences. For example, evidence of physical inactivities in children was found in a South African National Risk Behavior Survey. And it was reported there that 41.5% of children had insufficient daily physical activities. And for this reason, the study wants to investigate the relationship between physical activities and body composition among quantified primary school children in Kapeha, Eastern Cape of South Africa. What are the challenges that leads to the investigating of this study? Evidence provided in the literature review indicates a lack of consistent and representative data on physical activities and suboptimal level of body composition in young children, even in the foundation phase in primary school in South Africa. And we can see that if there is insufficient studies in certain area, meaning that many things that can be going on without being noticed. Given that demographic and socio-economic variables influence the level of physical activity and the rate of overweight and obesity, according to Parliament et al. 2022. So this perception that physical inactivities, overweight, and obesity in middle-income countries are associated more with children from higher socio-economic areas than those of resource-constrained regions has to be addressed. Because if it is not curbed, if it is not addressed, if it is not, addressed, as I said, there may be continuity of such lifestyle, which is dangerous to the future of our children. And to address these subjective methods or these subjective, these particular challenges. The study will be using actigraphy accelerometry tools to derive daily physical activities in the life of our children and in the life of the children from the selected schools. And also, bioelectrical impedance will be adopted to determine the body composition level in age 6 to 9 children in Quanta 5 primary schools of Kapeha. Then the questions, aims, and objective. The main question of this study is, what is the relationship between physical activities and body composition? Is there a relationship or not? And that is why we aim to investigate the relationship between physical activity and body composition. So to achieve this aim, the objective of this study will be, number one, to determine the level of physical activities among Quanta 5 primary school children in Kapeha, Eastern Cape of South Africa. And to achieve this, the study will use actigraphy accelerometer to determine this level of physical activities. And secondly, this study to determine the body composition status. As we know that there are different parts of the body, there are many body compositions, but the aspect this study wants to look into are body mass index, fat-free mass, fat mass, and also muscle mass. After these two variables have been determined, then the study will proceed to determine the relationship between physical activities and then body composition among these children. Methodology. We use a descriptive and inferential research design that is quantitative in nature. Why the use of the two? Descriptive statistics will help us to review the characteristics of the sample data that has been set. Then inferential statistics will be computed to gain more information about the effects, and that has to do with relationship, about the effect on the population being studied. That is, effect between this relationship between physical activities and body composition. And in these studies, descriptive analysis will be the first step. After that has been achieved in the statistical analysis process, then inferential will be introduced. Inferential statistics will be done. Then after that, there will be once-off survey that will be conducted. And this once-off survey will consist of two assessments. And the first assessment will be measurement of physical activities level. And this will be done by the use of actigraphy accelerometer. And the aim of this is to identify the level of physical activities in children within a week. What is the level of physical activities performed by them within a week? The children will be given this accelerometer, actigraph by name, to the home. They will wear it for a period of 1 week including sleeping, because we also want to know what is the sedentary level. So the only time they will remove this from their hand is when they want to perform any watery activities, or if they are walking in the rain, it has to be kept. So that's the only time this thing will be off their hand. And after that, we will measure the body composition status, and the aspect we are going to measure through the use of bioelectrical independence analysis will be body mass index. We'll measure also fat-free mass. We'll measure also fat mass, and at the same time, muscle mass. Then population and sampling method. This study we adopt the use of convenience sampling method. Though the way we adopt, the way we use this convenience sampling method is that the schools, there are 2 schools that have been pre-identified, and after we pre-identified them, we also conveniently select them for this study. And that means every other schools in the Quanta 5 will not be used. So it's only these two schools that have been pre-identified and then have been selected for this study. And according to the literature, we observe that there are 37 students, average in a class in Quanta 5. And these students, and we also assume that in each grade, there are 2 classes for each grade rather. And out of these 2 grades, we have average of 37. So we multiply 37 by these 2 grades, which will give us 74 per grade, 74 per grade. Then we multiply, since the age we are looking into are between 6 to 9, and we notice that this age falls between the grade of grade 1 to grade 4. So we multiply this grade 1, 74 by 4, which will give us 296 per school, and then multiply by 2 schools that we have pre-selected. And this means 296 times 2 will give us 592. So, excuse me. So for this study, we are having maximum participants of 592. And because we cannot go with this, we have to also narrow it down. The study adopts strategy method to select. After the school being selected through convenience method, we apply stratified method, and this method will help us to have both gender participation, proportionally, and so that there will not be discrimination, or there will not be any one gender will not be more or whatsoever. So we adopt stratified method to help us have a good representative of both gender. And then after that, we apply simple sample method, and we use Yame 1967 formula. And that formula states that n is equal to n over k, and then plus n, then margin of error. We use margin of error 0.5. We use 5%. And then n, capital letter n there stands for the population of the study, which is 592, which I call maximum. Then k there is constant, is 1. And then that e there is the degree of error expected. And also n is sample size, which is small n. And when we calculated this, we got with the margin of error 0.5. So we got 239. So the minimum participants for this study will be 239. And the measuring instrument that will be adopted, that will be used, are actigraph and then bioelectrical impedance analysis. So the accelerometry actigraph will be used to determine the level of physical activities, while BIA will be used to determine the level of body composition. Of course, we know that every study must have a good, must pass through certain ethics. There are ethics for a good study. And the ethical consideration we have put in place to be followed in this study are the following. First, before proceeding to either collection of data or doing anything from the participants or the schools, we collect approval from REC-H, and actually that has been at the final stage. We are expected to receive positive results because we have already done all the necessary corrections we were told to do, and the clearance will be given soon. And after the approval has been given, we will proceed to the Eastern Cape Department of Education, and it is because of the ethical clearance that we have not gone to that level. So immediately we get the ethical clearance, we proceed and write to them. Immediately they approve us or give us go ahead, then we proceed to the principals of the selected schools, and then we write to them. By the time they also approve us and welcome us, we give the students informed consent, information consent to their parents, information letter, then the informed consent. And then when we receive response from the parents, then each child, each student that will have positive response, that is to say, if their parents agree to proceed with their children, then those children also will be given assent form. We are not just the study is not to force anyone to participate. It is a voluntary participation we adopt, the way we are in use of. Of course, we have put into consideration a high level of confidentiality, and also there will be anonymity. Every data, every record taken will be saved. And also, to achieve good outcome, the study also have looked into using qualified research assistants, and we have quite a number of them around us, even in the department. And then the data analysis, the statistical analysis, SPSS version 27 will be used to report descriptive data in the form of means and standard deviation for physical activities and body composition of the age, gender, ethnicity, and level of physical activities. So that is to say, to achieve what we are studying, to achieve our objective, we have set in place, to use descriptive data analysis. Then after we have achieved that, inferential statistics also will be used to get more information about the uniformity. After the descriptive statistics has been, done, then inferential statistics will be also be used to gain more information about the effect of the population. And also, to determine body composition, which I've already told us that we are looking into 4 aspects, which is BMI, FFM, FM, and MM. And this will, help us to look into to look at the indicator of overweight, underweight, normal weight, overweight, and then obese. And the data required to achieve this is BMI score, BMI-Z score, rather, FFM, FM, and then MM. And the analytical tools we will use is CAT-SQUAD, and this will help us to see the association between PA and body composition variables. And CAT-SQUAD will help us to test this association. Though, as we know that CAT-SQUAD cannot establish whether one variable has a causal relationship with another, and that is why we will proceed to use one-way ANOVA, and we will apply one-way ANOVA to evaluate difference in mean value. And by the use of that, significance will be confirmed when p-value is 0.05. Then, to now know the magnitude, the extent of the relationship, Pearson correlation, because we said we are looking into the relationship between these 2 variables, which are physical activities and then body composition. So we have already determined the level of physical activities, and we have already determined the level of body composition. Then Pearson correlation will help us to show the level of relationship, the magnitude of the relationship between these 2 variables, physical activities and body composition. Then dissemination of results. The proposed results, because the result is still ongoing, the proposed study will be completed just to fulfill the degree in Master of Human Movement Science. It is research at the Nelson Mandela University. And when the result is being completed, the result will be reported to Eastern Cape of Department of Education, and also the principals of the selected schools will be notified of the outcome. And then the results, we propose the results will be presented to the at the research week in Faculty of Earth Science, which is what we are doing now. Then the findings, just as I told us earlier that the study is still ongoing, so we have not gotten the final results. But according to the literature, anticipated findings will be based, anticipated findings of this presentation will be based on our literature review and study design. Because based on what we have read, what has been done in the previous studies, so we say that higher physical activities level are associated with lower BMI. Don't forget, it is still a prediction. Then implications and recommendations. The implication has to do with the health promotion. So it is important to promote physical activity in schools, because this is a fundamental stage. This is where they can, we see that some children even obey their teachers more than their parents. So if this is being promoted at the school level, definitely they will abide with it and make use of it. Then policies, recommendations. We suggest that policymakers support physical activities program. If there are policies who support, who promote, who make sure that there is certain level of physical activities that is mandatory, definitely people follow what is being lawful. So then future research, there is a need for further studies to explore underlying mechanisms and develop physical activities intervention. Conclusively, studies have found that higher physical activities levels are associated with lower BMI. Just as I said, it has been predicted that studies that we are looking into may find higher physical activities levels. Then, from the previous studies, it has been also established that higher physical activities levels are associated with lower BMI. Higher physical activities levels are associated with higher fat-free mass. Higher physical activities levels are associated with lower fat mass. Higher physical activities levels are associated with higher muscle mass. So with this, it has been established that an increase in physical activities over a long time is associated with a decrease in body mass index in both boys and girls, as it was established by Sterling Johannessen et al. 2021. These are the references used. Thank you so much for listening. Nkosi Kakolo. You can please feel free to contact me if there is any comment, any suggestion, any questions from this email. Thank you, Nkosi Kakolo.
Thank you. That was a pre-recorded session. So there will be, sorry. Okay, I think that's better. So there'll be no questions, but you're welcome to email Mr. Bunmi or even Bertha if you have any questions with regards to the research. So now we're at the best part, food. So please, there's some refreshments at the back. And unfortunately, we're a little bit behind time. So if we can ask everyone to come back by Dr. van der Vente, 11, or can we say 11? Okay, so at 11 and we'll start the next session. Thank you. Thank you.